We'll be starting in another minute. Waiting for a few more people to join. So good evening, everyone. Today, this month, we have dedicated to neonatal neurology. And with continuing the theme of neonatal neurology, we all know that one of the leading causes of neonatal mortality in a country like ours is asphyxia, that is perinatal asphyxia. And one of the evidence-based modality which has been shown to decrease both mortality as well as morbidity has been therapeutic hypothermia. But after a major trial, that is Helix trial, there was some controversy regarding the use of this modality of treatment, especially for Indian and other Asian babies. To discuss more on this topic and this modality, we have with us our panelists from across the northern India who are the leading practitioners and are trained in neonatology. And this panel will be moderated by Dr. Vimlesh Soni. She is currently senior pediatrician and neonatologist at Chaitanya Motherhood Hospital, Chandigarh. So over to you, Dr. Vimlesh.
Thank you, Dr. Prakash. Am I audible?
Yeah, you're audible.
Okay. So as Dr. Akash has told that we are going to discuss a very important topic, therapeutic hypothermia. And as we all know that moderate to severe hypoxic ischemic encephalopathy continues to be a significant cause of neurological morbidity in term babies to the tune of 1 to 2 per 1,000 live birth term babies. And therapeutic hypothermia has been a time-tested modality to save these babies from neurological morbidity. So to discuss with this topic, we are having panel of doctors who are working in various institutions at Northern India. So our panelists include Dr. Pradeep Kumar Sharma, who is a senior consultant who is working at Deep Hospital, Ludhiana. Dr. Soumya Chaturvedi, who is working at Cloud9 Hospital, Dwarka, New Delhi. Dr. Sushil Sharma, who is working as assistant professor at ESCOMS Medical College, Jammu. Dr. Mubashir Shah, who is working as assistant professor at Government Medical College, Srinagar, and Dr. Hans Fesch, who is working at Meher Hospital, Dehradun. So we have some question answer session. So we will start the topic. Let me share my screen. Is my screen visible?
Yes, the screen is visible, but it's the last slide that is visible.
Yes. Okay. So now we will start the topic with our first question, that what is the mechanism of therapeutic hypothermia? And I would like to invite Dr. Mubashir Shah to answer this query.
Good evening. Am I audible?
Yes, you are audible.
Thank you. Good evening, all. This discussion is today regarding a role of therapeutic hypothermia in HIE. So we all know that whenever a baby does not initiate breathing at birth, and if that is not taken care of immediately, a cascade of reactions takes place which leads to injury to the brain of this particular baby. So at the outset, when this injury starts, what happens? The oxygen to various neurons, they start diminishing and the primary energy failure starts. So with this, this neurons start dying. There is swellings in the neurons, and then they become necrosed. So this is the immediate effect after ischemia and hypoxia. So this has already started. So what happens after that? There becomes a latent phase which roughly starts for 6 hours, and then after that there is secondary energy pump failure. Uh, what happens in that phase? There's a lot of reactions going on at molecular level where there's caspases or there are free radical injuries. These all happens after 6 hours. So this is the window between the primary energy failure and the secondary energy failure is this latent phase, which is the action window. Like we say in NRP, we have golden minutes. So we have these 6 hours where we can, if not fully reverse some part of the brain injury, we can reverse if we act in these 6 hours. So what is the action in these 6 hours? That is therapeutic hypothermia. So this therapeutic hypothermia will at least prevent some amount of brain injury and apoptosis and gliosis, which later on happens in first few months of the life. So how does this happen? What happens at the molecular level? So when we start this hypothermia, so it reduces the brain consumption of brain energy. So more and more and energy is needed. But if we start this hypothermia, what happens? The brain needs less energy, so it conserves the energy. With every 1 degree centigrade drop in temperature, so almost 5% of brain energy is saved. So when we start this therapeutic hypothermia, it decreases the excitotoxicity, like a lot of chemicals are released during this hypoxic ischemic encephalopathy, this injury, like glutamate release, and then it blocks the NMDA receptors. So what happens? This prevents the further neuronal injuries. So we discussed that free radical injuries, free radical species production, apoptosis, inflammation, and all these things can be prevented by timely initiation of therapeutic hypothermia if we start this within the first 6 hours of life.
So as Dr. Mubashir has highlighted, that it should be started before having reperfusion injury. So with this, we will be going to the second question, which will be answered by Dr. Soumya. That what is the selection criteria, prerequisites, and contraindication of therapeutic hypothermia? So Dr. Soumya, quickly throw light on this question.
Yes, ma'am. So selection criteria for therapeutic hypothermia is pretty straightforward and taken from New England Journal of Medicine. So the criteria is the baby should be more than 35 weeks gestational age. Presently, we are not cooling preterm babies because the adverse effects of therapeutic hypothermia like intracranial hemorrhage is more common in preterm babies, and there is complex etiology of encephalopathy in preterm, and we do not know the differences which therapeutic hypothermia might make. So presently our recommendation is to start more than equal to 36 weeks. As rightly told that the window should be within 6 hours after birth, because that is the window, that is a golden hour in which there is evidence that cerebral oxidation metabolism it fails progressively. So this is the area wherein in this latent phase we have to start therapeutic hypothermia. Along with that, APGAR score should be less than 5 for 10 minutes and resuscitation should be requiring for more than 10 minutes. This fairly suffices the criteria that the baby has underwent a significant level of injury requiring positive pressure ventilation or resuscitation for more than 10 minutes. But when we talk about cord gases, we have come through a lot of studies on this conclusion that pH of less than 7 and base deficit of more than 16. Now there is this was a very nice there was a very nice systematic review by Dr. Deepak Chawla, in which they have actually told that when mean cord pH of less than 7 was taken in LMIC and HIC, and when we cooled these babies with a pH of less than 7, we got a similar significant reduction in incidence of death before discharge. So this has also come from other studies in which even pH of less than 7.1 had a sensitivity of 74.2% and a specificity of nearly 98% for detecting moderate to severe encephalopathy. So the selection criteria has come from some amount of studies, and along with this, we should have a fairly good neurological examination wherein we establish that there is moderate to severe encephalopathy. Scoring can be done by any way, Thompson or NICHD. However, we should establish that the reason for which we are starting cooling, it should be beneficial to the baby. That is the primary. Encephalopathy should always be there. And along with that, if there are seizures within 6 hours of age, it definitely gives us an idea that the baby is encephalopathic. Next slide, ma'am. Coming to prerequisites to practice therapeutic hypothermia, and nowadays after Helix trial, we are actually mandated to follow this. Is number first is place, that we should have a well-established level 2 or 3 NICU, wherein a baby who is undergoing therapeutic hypothermia requires great degree or great precision of care. So a level 3 or level 2 NICU is well equipped to take care of such babies. Personal multidisciplinary team should always be available, and a follow-up program should be in place. We should have a radiant warmer. We should have a cooling device. Nowadays, it is said that a servo cooling device is preferable. However, if you have a non-servo device, then 1:1 sister and baby care should be there. We should also have all equipments to check babies' lab monitoring. We should have an ABG machine. We should have multi-parameter devices. We should have ventilators in place. In fact, babies may also be having PPHN, so we should also have devices and mechanism to take care of such things, like, for example, INO. Also, we should have protocols in place. We should have evidence-based practices and neurodevelopment follow-up, which is mandated now for therapeutic hypothermia. Contraindications have also come from once we have categorized the selection criteria, the others come into contraindications, or babies who cannot be cooled. So all babies who are coming in less than 35 weeks gestational age or less than 2 kg birth weight, major congenital malformations and known chromosomal abnormality, or any abnormality in which mortality is, there is a very high degree of mortality, there is no point in cooling such babies. Overt bleeding, need of FiO2 more than 80%, and severe PPHN. So these may come under relative contraindication and may have a component that maybe primarily HI is causing these side effects, and maybe they are not due to therapeutic hypothermia, which we'll come again to in next upcoming slides. However, these can also be taken up as contraindications.
So this comes to another question, then whether we should give therapeutic hypothermia to the babies who are having meconium aspiration syndrome with PPHN with birth asphyxia.
Yes, ma'am. So it is fairly common to see that babies who are compromised in utero, they have there is stimulation of peristalsis and there is relaxation of anal sphincter, and this allows passage of meconium. So meconium is very commonly associated with hypoxic ischemic encephalopathy, and MAS and HI is a perilous combination for newborns because there is associated risk of PPHN. And it may be seen that therapeutic hypothermia may increase pulmonary vascular resistance and worsen PPHN. And PPHN secondary to MAS is observed in 20 to 25% of term neonates with moderate to severe encephalopathy. There may be multiple mechanisms which may contribute to PPHN and cardiac dysfunction in HIE, including disrupted cardiopulmonary transition, and it is worsened when MAS is present due to hypoxia and acidosis. We sometimes use epinephrine and catecholamines in the delivery period. That is also known to precipitate PPHN due to pulmonary vasoconstriction and along with depressed LV function from hypoxic ischemic insult. And when we add therapeutic hypothermia, there is increased pulmonary vasoconstriction, increased pulmonary vascular resistance, and this may be due to direct vasoconstriction and potentially due to increased blood viscosity and use of catecholamines. So there may be multiple reasons that therapeutic hypothermia also corroborates to this. However, there are multiple randomized control trials which have shown that that there may not be a significant increase in therapeutic hypothermia, and this has also been highlighted by Helix trial. However, certain studies in which they have shown that hypothermia outside of clinical studies have shown higher incidence of PPHN. In fact, they've shown that 23 to 25% babies who are cooled for HI have PPHN, and 39% of mass who are cooled may have PPHN. Next slide, ma'am. So, as highlighted, that there may be multiple reasons why therapeutic hypothermia has an added effect on mass with HI, contributing to PPHN. And therapeutic hypothermia may also be responsible for abnormalities with LV and RV associated with left ventricular and right ventricular dysfunction. In all, when we go theoretically, definitely therapeutic hypothermia may have an increased or predisposition to worsening of PPHN. However, this has not been translated into clinical studies, and even when we talk about Helix, it was maybe there was higher incidence of mass pneumonia and sepsis in LMICs, which contributed to death, not per se PPHN. So that was mainly the reason that may have caused changes in outcome. However, when we talk about therapeutic hypothermia, as shown in this, if you see this figure, that therapeutic hypothermia increases pulmonary vasoconstriction. It even causes systemic vasoconstriction. There is high systemic vascular resistance. There is high LV afterload. Primarily, we also have LV dysfunction because along with that, there is systemic hypertension. We have sinus bradycardia. So cardioprotective, that sinus bradycardia may be cardioprotective, but it also contributes to decrease in cardiac output. So in total, therapeutic hypothermia may have an effect. However, PPHN is not a direct contraindication to start therapeutic hypothermia. Next slide, ma'am. So we have multiple strategies which I am not going into in depth when we have PPHN with therapeutic hypothermia. So nowadays our stance is that PPHN may be associated with therapeutic hypothermia. However, our treatment strategies of managing PPHN do not vary much. We definitely continue lung recruitment maneuvers. We go for surfactant because mass may be associated with the secondary surfactant deficiency. There may be poor lung compliance. So all lung recruitment strategies may be in place. We can definitely go for all sorts of pulmonary vasodilators, including inhaled nitric oxide. However, there may be certain minute twitching of strategies wherein a lower dose of sildenafil and milrinone may be considered because there is concomitant hepatic and renal dysfunction secondary to AKI with HI is commonly observed. However, this has not been confirmed in most trials, but a lower dose may be considered. Routine paralysis is avoided, which is nowadays a norm that we do not go for routine paralysis. It may increase systemic hypertension. We should have a very low threshold for doing neonatal echocardiograms, first to confirm the diagnosis of PPHN, and second to change our practice and change our pulmonary vasodilators. So our team should be strengthened enough to do frequent neonatal echocardiogram, and we have to very importantly maintain a very tight control of temperature. We should avoid severe hypothermia and hyperthermia because this will disrupt the balance and will increase the incidence of PPHN. So most important point here I'll give away is do not worry of PPHN associated with therapeutic hypothermia. It can be safely practiced. However, we should practice certain principles in which PPHN can be better managed with therapeutic hypothermia.
But I think there are different school of thoughts on PPHN on the baby of therapeutic hypothermia. A few school of thought says that the baby who develops severe pulmonary hypertension
Yes.
on therapeutic hypothermia, the therapeutic hypothermia should be terminated. So
Yes.
there are no clear guidelines on this till now.
Yes, exactly. And sometimes people end up stopping therapeutic hypothermia. So the stance is totally correct that either ways it can be followed.
So further studies are needed.
Yes, definitely. We need large RCTs here. Yes, ma'am.
Okay. So now we come on another question who is directed on Dr. Hanswet, that should late preterm neonate with encephalopathy be cooled?
Hello, ma'am. Good evening to everybody. So we have seen the TOBI trials, the cool cap trials, and the NICHD trials. They are all favoring cooling in the term or near-term babies, that is more than 36 weeks. However, the trials on the late preterm babies show adverse outcomes, and the results were in fact opposite. And I would like to quote one study that I found today, that is done by Dr. Rakesh Rao et al. It was a safety and short-term to see the safety and short-term outcomes of therapeutic hypothermia in preterm units between 34 to 35 weeks. So in this study, in contrast to the other studies, we found that 90% of the preterms as compared to 81.3% of the term units had more complications of therapeutic hypothermia. These preterms had more episodes of hyperglycemia, and the preterms also showed more incidence of mortality as compared to term units. And the preterm units also showed more signs of injuries on the neurosonogram, which were followed up after therapeutic hypothermia. Not only this study, there is another study which was done in the UK, which also showed that there are adverse outcomes following cooling preterm babies. So currently, as per evidence, we don't have robust evidence to start therapeutic hypothermia in late preterm babies. It should be very carefully done only in research settings, and so not routinely recommended for daily clinical practice. So we see more mortality, more hyperglycemia, more complications. There are only a small observational studies from CHND and Vermont Oxford network that have shown some feasibility and some signs of benefit, but still we need more robust evidence to start hypothermia in late preterms, and more trials are needed. There's a Cool trial as well as the NICHT Neonatal Research Network cooling trial in preemies that has enrolled around 168 preemie babies. The result is about to come, and I think these trials are to be waited so that we can get a proper answer as to when should we actually start cooling in these late preterms. So currently, no robust evidence is there to actually start cooling in late preterms.
So, as Dr. Hansa has told that preterm has some inherent differences as compared to term babies, that they are at more risk of IVH. They have different pathophysiology of birth asphyxia, and the data is also sparse on these preterm babies. So the data of term babies cannot be directly extrapolated on preterm babies. But I think this HOPE trial results are out, and they are published in JAMA Pediatrics in 2025 only, this year, April. And this showed that there was no difference in death and disability in the two groups at 18 to 24 months of age. And Cool trial results are yet to be awaited. So now we come to another question, that what is the metabolic effect of therapeutic hypothermia? So I would like to invite Dr. Pradeep Kumar Sharma to answer this query.
So the metabolic effects of therapeutic hypothermia, they are both good and they are both bad. The good ones are there is decreased cerebral metabolism, which leads to neuroprotection. It reduces ATP depletion as resulting in reduced cell death. That's why we use it. It reduces reactive oxygen species and cytokines, leading to less inflammation and a reduction in oxidative damage. But also, there are some effects that are harmful, like increase in the risk of glucose and electrolyte imbalance, so requires careful monitoring for these. As previously mentioned, there is effect on the drug clearance because of the hepatic and renal dysfunction, so we need to modify and adjust the dosages of these medications. There is also increased risk of arrhythmias, especially during rewarming. Why this happens? During hypothermia, metabolism slows and cells retain potassium. And during rewarming, potassium is released from the cells and risk of hyperkalemia if not monitored. And also cold-induced diuresis leads to losses of potassium, magnesium, and calcium. So during rewarming, there is rapid shift of these electrolytes. So very careful monitoring is required, as this sympathetic overdrive may be arrhythmogenic. So this is all.
So another question is cooling beneficial for mild neonatal encephalopathy? So I would like to invite Dr. Sushil Sharma to answer this question.
Good evening, everybody. So mild HIE has been shown to be associated with a lot of moderate to severe disability in quite a number of patients. And especially the cognition, motor, and language scores have been quite affected in mild HIE as shown in this PRIME study. But despite this, we have very less evidence because neonates with mild HIE have been systematically excluded from most of the major RCTs. There has been some data. So some of the mild HIE suffering neonates were inadvertently included in few RCTs, and there was this meta-analysis from these 4 RCTs where 91 infants with mild HIE were seen, and 45 of them were treated, and 46 of them were included in the control group. There was some marginal benefit, but again, the confidence interval is very wide, so very hard to say. Next slide, please. And then there have been some encouraging results from this MARBLE study where a total of 31 infants were included and only 1 infant developed cerebral palsy and showed some good improvement in Bailey 3 scores also. There was again one pilot study, an RCT from 6 UK and Italy centers, which failed to show any improvement in MR biomarkers. So there's a need for well-designed multi-center RCTs, and there are some, at least 3 of them, which are ongoing. One of them is FOMET, which is right now recruiting neonates in UK and few other European countries, and they target for 26 neonates with mild HIE. Then another one is a longitudinal US school PRIME study. So once these RCTs are over, we should have some more answers whether we need to pool neonates with mild HIE or not. So as of now, there is insufficient evidence, and it should be used only for moderate to severe HIE.
So as highlighted that in mild HIE, there is a speculation of more slow cell death. So it is speculated that they are more likely to respond to therapeutic hypothermia, but it has not shown till now by research. And there are a few trials as has been highlighted, like COMET trial, which is ongoing. But another issue is that when we cool these babies with mild HIE, they require an ICU stay, separation with mother, delayed feeding, and different lines and all. So they may not likely to show they are at more risk of this modality. So this is questionable whether the mild HIE babies should be cooled or they should be managed conservatively. So this question will be answered probably by the upcoming trials. So with this, we go on to another question, that what all devices are available for therapeutic hypothermia and how does these devices work? So Dr. Hans will answer this question.
Thank you for the question, ma'am. We'll basically see what modalities are there. There are 2 modalities. First is selective head cooling and second is whole body cooling. Whole body cooling is the worldwide accepted modality of cooling nowadays. So we'll be discussing modalities for whole body cooling. In briefly discussing the selective head cooling, there's basically a cap wherein the cold water circulates to maintain the temperature between 33 to 34. Can I have the next slide, please? When we started cooling, when we didn't have the servo control devices, there were various methods which we used to cool the babies. Number 1, we used ice and gel packs, but there were more temperature fluctuations and cooling might sometimes worsen and it might even injure the brain more. So, but it was more labor intensive and required more 1:1 nursing. Some people use fan, which cause increased shivering and neuroprotection may be lost. And sometimes people even used water bottles and tap water, but which was only effective in temperate climates. But all these practices are now outdated. We have moved on to better devices. A few years back, around 5-7 years back, I was using this Mira Cradle device, and it was actually working pretty well. And it is very good for low-income countries like India, and it is a very cheap device. It does not require any electricity. The main mechanism of its action is that it has a gel pack which are placed on the Mira Cradle. These are phase changing packs, and FS29 and FS21. So basically, they try to extract the heat from the baby's body when the baby is put on this Mira cradle, and gradually the baby's temperature is brought down to 33 to 34 degrees Celsius. But here also we need to keep monitoring the rectal temperature regularly, and it is also labor intensive and it also requires 1:1 nursing. If the temperature goes more above 34 degrees Celsius, we need to uh, add the second phase changing material, that is FS21, which will get the temperature down. And if sometimes the temperature goes down below 33, we might have to manually switch on the warmer to get the temperature back to 33 to 34 degrees Celsius. So this is a good method to cool if you have a low budget. Can I have the next slide, please? So coming as we progressed, now we have good server controlled machines, but they are a bit expensive. But this has become the norm of cooling now. There are various devices by the name of Criticool, Tectotherm Neo, Blanket Roll 3, Arctic Sun 5000. The commonly ones that are used are Criticool and Tectotherm Neo. And in India, we even have a device by the name of Neotherm, which I'm using myself. So the basic principle here is that instead of a gel pad, we have a blanket which is connected to the machine, which pumps in water at the temperature, which will get the temperature of the baby down to 33.5 degrees Celsius. It dynamically and actively monitors the temperature of the baby, as there is a sensor for this. There's a surface sensor that detects the surface temperature, and there is a core sensor that is inserted inside the rectum of the baby. So it detects both the surface and the rectal temperature and accordingly modulates the temperature of the water that is circulating in the blanket to get the temperature down to 33 to 34 degrees Celsius. It is more accurate as it is itself automatically controlling the temperature. It is less labor intensive, and it's able to meet our requirements of the induction phase, the maintenance phase, and the rewarming phase. So especially useful in the rewarming phase, where we can actually set the required temperature of 36.5 to 37 degrees Celsius, and we can even set कितने घंटे में हमें उसको रिवॉर्म करना है. So we can set that timing to 12 hours. So this is a better machine to procure if we want to cool our babies in a better controlled environment, and it has less chances of the error. Can I have the next slide? So as I've already discussed, the mechanism in the servo control, it is an automated system to maintain the target temperature precisely using a feedback from the continuous core.
We can skip this slide.
Yes, I think we can move ahead. Thank you.
Okay. So to conclude, whatever device we are using, we should know how to operate that, how to monitor the baby. In our hospital, we are using Mira Cradle, which is phase changing material device, and that non-turbo control, and we are getting good results with that also. So coming to the next question, which is directed to Dr. Mubashir, and about any other options for therapeutic hypothermia for low resource setting.
My co-panelist has already discussed about few devices by which we can cool the babies. So other devices which are there, but I think they are not standardized. My other co-panelists can agree with me. So there used to be a passive cooling. So what happens in this? We used to switch off the radiant warmers and incubators, and we used to keep the baby cool naturally. But still here we used to put the rectal or esophageal probe, and we used to monitor the temperatures. So it's cost effective, but I think it's not standardized. So still not used in most of the places. So ice or gel packs, as Dr. Hans was discussing about it, so they are quite inexpensive and can be set up very quickly anywhere, but there are risk of frostbite and temperature fluctuations, so need to be taken monitored very carefully. Then there is PCMs. PCMs have like Meracradle, and these are phase changing materials. So what they have their freezing temperatures and they have their melting temperatures. So whenever the temperature fluctuates, so they try to absorb the heat or they try to give the heat. So the good thing in them is that their own temperature does not change. So they extract the temperature from the surroundings. So here, what is the surrounding? Baby is the surrounding. So we regulate the temperature and we cool the babies with these PCMs. So the other one is like evaporative cooling with fan and wet cloth. I think nobody will be using this nowadays because it's quite unpredictable and we don't know what's happening. And temperature regulation is quite I think very difficult to maintain. So these are other devices apart from what Dr. Hans has discussed already. Thank you.
These devices are being used by people, but the data is still unavailable about their use. So now, will either mild or deeper hypothermia be effective, or how one should monitor a baby on therapeutic hypothermia, and how rewarming should be done? So, Dr. Sushil, would you like to answer these questions? Hello?
With hypothermia, there's a U-shaped curve of neuroprotection, and it has been shown that temperatures above or below this curve, they provide no additional benefit and may be potentially harmful. So we need to maintain the temperature between that range. Shankaran and colleagues, they write, examined this question in a trial. It was a 2x2 trial where they decreased the temperature up to 32 degrees and continued hypothermia for 120 hours and compared it with standard of 33 to 34 degrees Celsius at 72 hours. And this trial had to be closed prematurely because of the safety issues and futility. There was a non-significant increase in mortality and significant increase in need for ECMO and IMF. And in other trials, it's been shown that there is no additional benefit, and in fact, there's increased need of vasopressors, etc. So current evidence is for the temperature range between 33 degrees Celsius to 34 degrees Celsius for 72 hours, which provides maximum benefits with minimal side effects. As far as monitoring of babies on hypothermia is concerned, so they require very close monitoring. Continuous rectal temperature monitoring is very crucial for these babies. And like one of the co-panelists just discussed, that we have got the surface temperature probes and the rectal probe. So we need to monitor the temperature and maintain the baby in that range of 33 to 34 degrees Celsius. We also need to monitor and chart the vitals, including the heart rate, invasive blood pressure, the respiratory rate, every hour for the duration of the hypothermia. Then we need to record our ECGs continuously, like Dr. Pradeep was saying that there's a high risk of arrhythmias associated, especially during the rewarming phase. So we should be looking at the ECGs continuously. Then the EEG, there's high risk of seizures and sometimes there can be electroclinical dissociation. So we need to have this attenuated EEG and we need to monitor it continuously. We need to examine the baby neurologically every 12 hours, monitor the urine output every 6 hours, and skin integrity can be checked with every change in shift or every 6 hours as feasible. As far as investigations are concerned, because these babies are at a high risk of hypoglycemia, electrolyte dysfunctions, so glucose should be monitored at least every 6 hours. Blood gas would depend on the cardiovascular status of the cardiorespiratory status of the neonate on the initial day. So it can be done 6 hourly or as indicated by the condition of the baby, whether the baby is in shock or on PPHN. And then it can be done every 12 hours or as indicated on day 2 and 3. Renal function tests and electrolytes once would suffice, and hemogram only if required, and we can also do neurosonogram as indicated. Now coming to rewarming, so we know that we do slow gradual rewarming of these units. So we increase core temperature by 0.5 degrees Celsius every hour until we reach this temperature of 36.5. And Dr. Hans explained very well that in Tecotherm we can actually set the temperature and the time duration, and the machine will automatically take over. When core temperature reaches 36.5, we remove the patient from the cooling device and we reactivate the radiant warmer and monitor and document the infant's temperature with skin probe.
So this rewarming phase is very, very important because many complications like arrhythmias or seizures are more likely to occur in this rewarming phase. So monitoring is crucially required at this phase also. Then coming to another question, which will be answered by Dr. Soumya, that when one can consider immediate termination of therapeutic hypothermia before designated 72 hours duration.
So yes, there is a very, these are some of the indications which are commonly used in clinical practice. However, premature discontinuation can lead to worsened outcomes. However, when we face hemodynamic instability or refractory shock, severe PPHN which is not responding to our conventional management, bleeding, especially severe intracranial hemorrhage, and certain adverse events like severe coagulopathy. Again, however, Cochrane review also states that it is only thrombocytopenia and sinus bradycardia which is higher. And however, discontinuation was the most common reason which has been found in trials for discontinuation is inexperience of therapeutic hypothermia in some centers. However, these can be still considered as requirements that we should stop continuing therapeutic hypothermia and stop it before 72 hours of designated period.
Rightly said, Dr. Soumya. So another question is current therapeutic window optimal or could it be shortened or prolonged? So Dr. Mubashir, would you like to answer this question?
Yeah, so currently the recommendations are that the initiation should be within 6 hours of the insult. Then as previous co-panelists have mentioned that the standard duration is 72 hours and the target temperature is 33.5 plus minus 0.5 degrees Celsius. And then slow rewarming should be there with the 0.5 degrees Celsius every hour, and it should be up to 6 to 12 hours. So why is this 6 hour window? Because we have already discussed in our first slide that there is latent phase and there is secondary pump failure, there is primary pump failure. So these 6 hours are there which can benefit if we start therapeutic hypothermia. Now, can we start it earlier? So can we start it before 6 hours? Yes, there are some meta-analysis which has shown that the trend towards improved outcomes, and if we started before 6 hours, if the baby reaches before that to our unit and we can start it, yes, there are outcomes which are better. But then there is issues like feasibility issues, like babies are coming from referral units and it takes sometimes time. So those are the challenges where we can sometimes stuck and we don't connect them before 6 hours. Can you go to the next slide? So could we prolong this 6 hours period? So can we go it up to 12 hours or beyond that? There are some trials which have enrolled neonates up to 12 hours in their trials. So there is some benefit, but those benefits were not statistically significant. So we can still go up to 12 hours if the baby is coming after 6 hours to our unit. So up to 12 hours, yes, we can start if there is still evolving encephalopathy. But beyond 12 hours, I think the evidence is still lacking. So up to 12 hours, yes, we can do that. So about the duration, we are saying that it should be up to 72 hours. So can we prolong that also? Are there any benefits if we go beyond 72 hours? Some studies have tried it and they have gone beyond 72 hours, but they have shown that there is not much benefit if we prolong it beyond 72 hours. So there are some increased risk adverse effects like bradycardias, coagulopathies. So still the consensus is that it should not go beyond 72 hours. Thank you.
So till now, as the evidence is available for before 6 hours and till 72 hours. So with this we come to the next question. Does infection and inflammation exposure in the perinatal period in combination with neonatal encephalopathy offer potentially beneficial preconditioning or might it obviate hypothermic neuroprotection? So Dr. Soumya, you are invited for this question.
Yes, ma'am. So there are certain perinatal infections like some viruses like CMV, chickenpox, rubella, or bacterial infections of placenta, fetal membrane. So they are very concomitantly associated with the HIE. So it is very, I mean, the studies on this are very limited. However, some degrees of certainty has been established that perinatal infections limit neuroprotective effects of therapeutic hypothermia, and mortality rate in hypothermic septic neonates is found to be higher than twice as compared to febrile neonates. And therapeutic hypothermia is not neuroprotective in newborn rat models, and it has been shown that there was loss of brain area after inflammation sensitized hypoxic ischemic brain injury, and it was not reduced by therapeutic hypothermia. So we can actually say that normothermia and avoidance of hypothermia should be the standard of care in these low resource settings. Inflammatory and cooling cascades following neonatal asphyxia are dependent. Basically, the whole idea is that therapeutic hypothermia prevents this cascade of apoptosis and necrosis. However, when we fall into the inflammatory cascade of infection, there is this apoptosis and necrotic pathway is invariably activated, and therapeutic hypothermia hence fails to offer benefit. However, there are a lot of heat shock and cold shock proteins involved, and a lot of studies are still underway, and we may actually know more answers later. But presently, normothermia and avoidance of hypothermia should be the standard of care when we see perinatal infections, and therapeutic hypothermia may not offer benefit in these babies.
Okay, rightly said. So now we come to the final questions. So what is the evidence of therapeutic hypothermia? What are the key points of HELIX trial? And should we change our practice based on this famous HELIX trial findings? So Dr. Pradeep, I would like to invite you to answer these important questions.
So the evidence for therapeutic hypothermia is very, very convincing because multiple trials, including the TOBI trial, NICHD trial, COOL-CAP, and even Cochrane meta-analysis, because often Cochrane is mostly inconclusive, but here it's very conclusive, more than 1,500 babies, and the risk reduction was almost 25% for death or disability, so very high quality evidence, except the HELIX trial. So why is it different? Let's see in the next few slides. So it's a multi-center randomized open label controlled trial in 7 tertiary NICUs, including India, Sri Lanka, and Bangladesh. 400 plus neonates with moderate to severe HI. So in the primary outcome for death or moderately severe disability, there was no difference. But death alone was higher in the hypothermia group. So now the question is, with a higher death rate in the intervention group, is it ethical or justified to continue therapeutic hypothermia in low or middle income countries? Let's see the next slide. So the issues with this trial was, one is the inclusion criteria. So the sentinel events and COD PH were reported in almost only just 10% of neonates. This raises the doubts about whether neonates truly had acute perinatal asphyxia or not. Many neonates in the hypothermia group were already hypothermic on admission because they were not properly transported on way. So they had higher mortality. There were neonates who were discharged against medical advice, and their outcomes might have biased the mortality analysis. So if you include them, that shifts the confidence intervals to cross the line of no difference. So that difference may become not significant. There were concerns about blinding, and also the results were driven by one single center. 70% of neonates had poor neonatal peripartum care and transport. So the generalizability is limited in this. There was a high incidence of sepsis, including abnormal TLC, both in the hypothermia as well as the control group. So that suggests that early onset sepsis might have confounded the results. Also, there was higher encephalopathy in the control group that raises the questions about its interpretation. There was no interim analysis planned despite prior evidence of potential harm from hypothermia in similar settings, so considered a missed ethical safeguard. So, in conclusion, Helix trial results may be influenced by multiple confounders: poor perinatal care, sepsis, inadequate masking, and selection bias. So, unless we do a further research on this, it's very difficult to conclude on this basis and change the practice. But, next slide, please. After this trial, now cooling in India still should be in an experimental phase. It cannot be a standard of care because this trial was very otherwise well defined, well designed trial. So the implementation should be strictly limited to clinical trial settings with informed parental consent and intensive monitoring. Structural neurological examination must confirm that we have moderate or severe encephalopathy at the time of starting therapeutic hypothermia. And there must be facilities supporting invasive ventilation, cardiovascular and infection support, thermoregulation, continuous monitoring, and long-term follow-up.
So, as rightly said, that although this trial has been critically analyzed on various forums, but the evidence behind therapeutic hypothermia cannot be ignored. So, the clinical judgment and the informed parental consent and monitoring and fulfillment of criteria for inclusion that should be strictly followed. So, with this, we can conclude that as therapeutic hypothermia is being used for more than 2 decades, and the inclusion criteria are very straightforward, which has been highlighted in previous slides. So they should be followed, and it should be done in any area, in a NICU where level 3 or level 4 facilities are available, and all kinds of monitoring, including amplitude integrated EEG and neuroimaging facilities, and good nurse patient ratio facilities for inhaled nitric oxide is available where it should be offered. And definitely servo control devices are having better evidence as compared to non-servo control devices. And if non-servo control devices are being used, there should be 1:1 nurse patient ratio. And it has been strongly recommended by NNF that there should be a national registry where all neonates with moderate to severe HI who are being pooled should be registered. And there should be a these kids should be followed up religiously for neurodevelopmental outcome. So with this, we will conclude the session, and I would like to invite the queries who the participants are having. So they can unmute themselves and ask the questions, or they can type their question in the chat box.
Before a question arises, can I add one thing?
Yes, sir, definitely.
Okay. There was a slide on therapeutic hypothermia and PPHN, meconium aspiration and PPHN. Although they concluded that there was no significant difference in the outcomes, if I can go to that, but it was 1.3. The relative risk was 1.36. Yes. So randomized trials have not shown an increase in PPHN with therapeutic hypothermia. RR 1.36, but you see the CI, which is 0.95 to 1.96. So it's very close to 1. What happens is most of these trials, they don't have the primary outcome when they calculate the sample size. Then the increase in PPHN is often not the primary outcome. So often these studies are underpowered to address that particular question. So as it was already concluded that in such a case, we need a bigger sample size that might have a narrow confidence interval and may a significant increase in PPHN with therapeutic hypothermia in MAS also.
Very true, sir. Very true.
There is one question. Is therapeutic hypothermia to be strictly limited to clinical trial setting? This is asked by Dr. Ashwini Mahajan. So, Dr. Pradeep, would you like to answer this question?
Yes, yes. See, after the Helix trial, which was, as we said, very well conducted study, although we have critical appraisal with so many limitations also, more than 400 babies. So at this stage, it cannot be a standard of care in low middle income countries because clearly there was increase in mortality, and the reasons why there was increase in mortality was one of these reasons were, of course, early on sepsis is a big confounder, and that is so common in our settings. So in such a situation, those centers where we have very good monitoring, we have ventilation, we have good care for invasive BP monitoring, blood products available because risk of bleeding is also there, and follow-up can be ensured. In that case, with the parental consent, we can go ahead with this therapeutic hypothermia, not as a routine in every setup in this country.
Okay, so another question is role of sildenafil in PPHN plus HIE plus meconium aspiration syndrome. So, Dr. Soumya, would you like to take this question?
Yes, ma'am. So basically, yes, sildenafil can be very easily used in babies associated with babies who have PPHN along with therapeutic hypothermia. However, some studies may tell that with the dose may be altered slightly. However, it is a good pulmonary vasodilator, and the routine management principles of PPHN, which involves use of sildenafil, can be definitely be undertaken in babies who have PPHN on TH.
Yeah, so as rightly said, the management of PPHN will remain same as otherwise the babies who are not on therapeutic hypothermia. Should rewarming temperature be 0.5 or 0.2 degrees centigrade? So it should be, the range is between 0.2 to 0.5 degrees centigrade. Then another question is, how does hypothermia during admission affects therapeutic hypothermia? Dr. Hans, would you like to answer this question?
Yes, ma'am. That's a really good question because as we've already discussed in our discussion, that hypothermia is actually damaging for neuroprotection. So obviously, if we know that the baby is in HIE, we can start passive cooling at the center where we have the delivery. So passive cooling in the sense that we can manually turn off the warmer and then transport in an ambulance without the warmer, and it quickly transport to a level 3 nursery where the child can be started cooling.
Is it truly a guideline? I doubt.
Just to add to that,
Huh.
so patient doctors should not confuse hypothermia with the therapeutic hypothermia. So basically, the therapeutic hypothermia is a controlled hypothermia. So if you have to transport a baby, it is better to maintain normothermia rather than unregulated temperatures, because as discussed, one of the problems with the Helix trial was the temperature, admission temperature was very low, and with each degree fall in temperature, the mortality increased by 15 to 20%. So if you are transporting, either you can use a transport hypothermia device, but while transporting, do not use passive cooling. So there is a difference between passive cooling and the controlled cooling. So therapeutic hypothermia is a controlled cooling where we do not allow the temperature to fluctuate more than 0.5 degrees Celsius. More the fluctuations, more will be the results will be much worse.
Even it is said that even if you are cooling a inborn baby and you are transporting from labor room to NICU, then also you should not transport it in hypothermic state.
Both hypothermia as well as hyperthermia can be detrimental.
Yes, yes. So another question asked by Dr. Deepa, that should we do passive cooling during? So it has already been answered, Dr. Deepa. You must have got your answer. Then Dr. Naman has asked, can we initiate therapeutic hypothermia in intubated babies on multiple inotropic support? What should be our BP targets in such cases? So the monitoring should be done as has been highlighted in the monitoring sheet. So a baby who is on inotropic support, therapeutic hypothermia can be started, but a baby who is on catecholamine refractory shock, this is a relative contraindication for therapeutic hypothermia. And as has been said in earlier slides also, that that birth asphyxia per se will be responsible for shock. So most of these babies will be having hypotension and requiring inotropic support. But refractory shock is a relative contraindication for therapeutic hypothermia. Any other question?
There's a question there. Can therapeutic hypothermia lead to severe coagulopathy due to clotting factor deficiency other than thrombocytopenia as complications mentioned? Can we continue in such cases? Yes, therapeutic hypothermia can lead to coagulopathy because hepatic dysfunction occurs and due to which factor 2, 7, 9, 10 can be affected, leading to deficiency as well as clotting factor deficiency. So this can lead to the risk of bleeding, and when a major bleed occurs, we might need to discontinue therapeutic hypothermia in such cases.
I'm not able to see this question and any other question also.
It's
Q&A box, not the chat box. Q&A.
Okay.
I think one of the things which was, although we have covered a majority of the things, one of the things which was not discovered was feeding during therapeutic hypothermia. So now there are trials that you don't have to wait for 72 hours or till the baby gets rewarmed to the normal temperature. If otherwise baby is hemodynamically stable, feeding can be started during therapeutic hypothermia per se. And other thing, as Dr. Pradeep said, that it is not the end of the road to therapeutic hypothermia. The only thing is that centers who have monitoring or who are level 3 NICUs with a good follow-up should give only therapeutic hypothermia. Small centers with limited facilities should not offer therapeutic hypothermia. It is just like if we remember about the antenatal steroids. There was one trial which showed a harm regarding the antenatal steroids, but that did not stop us for using antenatal steroids till WHO came up with a large, well-supported trial where we showed that antenatal steroids are useful, and we all know now how important antenatal steroids are in treatment of preterm babies. Similarly, WHO is also planning a similar study for therapeutic hypothermia. I think after that trial we can draw conclusions, but as of now, therapeutic hypothermia should be offered, but should be offered only by the centers who have good dedicated level 3 NICU with a good monitoring and good follow-up.
Sir, can I ask one question?
Yes.
Hello.
Yes.
Yes, myself, Dr. Ravi Sekhar Singh from Ranchi, Anvi Newborn and Child Hospital. Is it necessary to have amplitude integrated EEG for therapeutic hypothermia?
Yeah.
Is
Actually,
it mandatory, or we can monitor somewhere in a simple EEG, or we can monitor clinically?
these patients are having high risk for electrical seizures. So, and they are more at risk while rewarming phase. So continuous EEG monitoring is mandatory and has been highlighted in various monitoring sheets also, like Sanat and Sanat staging and various monitoring sheets which has been shown in the slide also. So according to the guideline, amplitude integrated EEG is must, because you will not be able to find electrical seizure. You will be able to assess the clinical seizures only while clinical monitoring. So it is must.
Okay, ma'am.
Also, we should prevent shivering in this patient when therapeutic hypothermia is ongoing, because that may worsen the clinical situation. So they might need adequate sedation and pain relief also.
Yes. I think we have answered all questions. So, Dr.
I think
Akash,
there is one more question. I think Dr. Pradeep can answer this. As a pediatrician or neonatologist, what is the legal implication of not giving or giving therapeutic hypothermia to eligible patient?
Okay. In India, because after the HELIX trial, it's still not the standard of care. So even if you are not giving therapeutic hypothermia after perinatal asphyxia, you cannot be legally challenged on that basis. But if you are giving therapeutic hypothermia, then you must take consent from the parents. including the adverse outcomes that can occur because of therapeutic hypothermia itself. And your unit should be equipped with all those facilities which are required along with therapeutic hypothermia.
I also still has this query. Isn't it a standard of care in India after Helix trial? It is questioned, but it has been omitted from standard of care. I think it should be offered.
It has been now changed to that level where, just like an experimental setting, you will have the facilities for that these are the facilities, and there will be monitoring. You will have to take consent for that, and you will have to ensure follow-up of these babies, just like postnatal steroids that we were doing, something similar to that.
But
Can I add something to the discussion?
yes, sir.
I feel that if you have to be very honest with your patient, and if you, yes, it is the standard of care. If your center does not have the facility to cool, you have to inform your patient that this facility is available at other centers, and if you want to take your baby to that center, you can. Because we might be in a legal
suit. Changed till now.
See, we can go by the clinical position guidelines of the NNF or anybody in our country. Like right now, we can follow the NNF guidelines for that. So just like the concluding statement of this presentation, we can follow that.
Dr. Harsh, you want to highlight?
It is just like if you have a patient with birth asphyxia, you can offer therapeutic hypothermia. If you're not having, it is not a problem because you have told the patient that there is something called as therapeutic hypothermia. Then it is the purview of the parents whether they want to go for it or do not want to go for it. So you are right in both the ways, by not giving or by offering them, provided the patients agree for the same. Definitely you have to offer, but it has the parents, it is up according to the parents' will whether they want to do it or they do not want to do it. But yes, it should be offered to all patients.
And it should be documented. There should be documentation.
As Dr. Pradeep has rightly said, we need to take consent. Both for that it has been offered to them, they have not accepted, or it was offered to them, they have understood the complications and they have accepted it.
Yes.
And
Because
it has to be according to a stringent criteria. It should mild HIE baby should not be cooled. Similarly, moribund baby should not be cooled. There we have strictly no.
Yes, definitely. So we should offer that, and we should take consent, and we should properly document this into the patient file. So I think we have come to the end of the session. Any more question? If I'm not able to see. I think we have answered all the questions.
Yeah, I think.
So we should conclude the session, and thank you all panelists and Dr. Akash for taking